This video demonstrates a technique for sacrospinous hysteropexy from an anterior approach using the Neomedic Anchorsure device. The authors of this video have received educational grant funding from Neomedic. First, we will introduce the Neomedic Anchorsure device. This is an animation showing the basic components of the Anchorsure device. And now we present our surgical case. Now we present our case of a 72-year-old female with uterovaginal prolapse to her hymen. She has not had prior prolapse surgery and is sexually active. Additionally, she has a small cervix and uterus with no history of postmenopausal bleeding. We start with a view of the patient's anterior dominant uterovaginal prolapse. We have placed an Alice clamp halfway from the hymen to the cervix to serve as a handle. First, we inject the epithelium with a diluted local anesthetic with epinephrine to help us develop our partial thickness dissection plane. Next, we make a triangular incision whose distal tip allows enough room anteriorly for a possible mid-urethral sling to be performed if indicated, and whose base is just above the cervicovaginal junction. We then grasp the distal tip of the incised triangular epithelium and dissect the superficial layer from the underlying endopelvic fascia with Metzenbaum scissors. Here, the assistant helps to lift the bladder enough to help the surgeon identify the partial thickness dissection plane. If an adequate injection was made initially, this dissection progresses smoothly. Next, we have placed Alice clamps on the right side of the vaginal incision and are dissecting into the same partial thickness plane lateral to the bladder. The same dissection is then performed on the opposite side, which is not shown. Now, the surgeon is dissecting the distal bladder off from the top of our incision. This is followed by dissecting between the bladder and cervix to expose some of the subepithelial cervical stroma. Here, the surgeon is performing the sacrospinous ligament access dissection, which is performed against the right vaginal epithelial flap. Once this retroperitoneal space is entered, the scissors should fall into the space in the absence of pelvic scar tissue. The ischial spine should be palpated through this tunnel, and the sacrospinous ligament should be cleared of surrounding tissue. After this, we will perform our anterior repair. Here, we are already in the middle of our anterior repair that was started distally near the bladder neck. The surgeon plicates the endopelvic fascia in the midline with a vertical row of horizontal mattress sutures using a 2-0 monofilament delayed absorbable suture. Once we have reached the proximal portion of this repair, we will use a 2-0 silk suture to include the retroperitoneal proximal cervical stroma into the repair, which effectively reattaches the repaired anterior wall to an apical structure that will itself be pulled towards our final sacrospinous support. This labeled model demonstrates the target area for sacrospinous ligament fixation. In order to best avoid neurovascular injury, the fixation should occur about 2 centimeters from the ischial spine and within the middle of the sacrospinous ligament. Our technique is to place a permanent monofilament suture and a monofilament delayed absorbable suture into the right sacrospinous ligament. First, we will see an animation of the basic steps of deploying the Anchorsure device. Next, we will see the device applied in our surgical case. Now, the surgeon uses their inserted right hand and the left fingers to stabilize the outer sheath while their thumb presses on the applicator knob to deploy the device. Stabilization of the outer sheath is important as there is the potential for the outer sheath to pull back without an adequate deployment of the anchor if the outer sheath is not stabilized. It is important to ensure that the distal end of the device does not move from the previously designated safe injection area while performing this step. After deployment, the applicator is removed first and then the outer sheath. The surgeon then confirms the secure fixation. Now we will show you our technique for apical suture attachment. The permanent suture is sutured through the middle of the retroperitoneal cervix and will not be brought out through the vaginal epithelium. The delayed absorbable suture is then sutured through the ipsilateral edge of the retroperitoneal cervix with one end of the suture, while both ends of the suture are ultimately brought out through the vaginal epithelium. Now we are demonstrating these maneuvers in our surgical case. First, with our permanent suture, and now with our delayed absorbable suture. This diagram depicts the closure of our triangular anterior vaginal wall incision. We first close the distal end of the vaginal epithelium with a 2-0 running braided absorbable suture. However, between the suture throws through the vaginal epithelium, we will incorporate the underlying endocervical fascia. In order to do this, we will change the way that we hold the suture needle into the form of a backward C shape as seen here. Utilizing the backward C orientation helps the surgeon efficiently incorporate the underlying endocervical fascia. After we have closed the vertical aspect of the vaginal incision, we tie down the sacrospinous sutures to resuspend the apex towards the deep pelvis. Now we will close the remaining horizontal incisional space by utilizing the backward C suturing technique. Utilizing the backward C orientation is particularly helpful when suturing in the deep lateral vaginal fornix. Finally, we see our well-supported vaginal apex and anterior vaginal wall. Thank you.